Can you describe a bit how the information you provided on hypo would apply to hyper? And there's a second part to this question, but we'll...
Yeah, okay, the first part of my talk would also apply to hyperkalemic periodic paralysis. So the P1 fraction and the P2 fraction, that's exactly the same for hyperkalemic periodic paralysis. The difference between hypo and hyperkalemic periodic paralysis is that in hypokalemic there is this accessory pore which conducts sodium, and in hyperkalemic periodic paralysis there's also an increased sodium influx, but not through this accessory pore, but through the central pore. So the pathogenesis is very similar, but the conditions how to have this pathologic additional sodium influx are different. So it depends on circumstances when this additional sodium ions will be conducted through the membrane. So, but in summary, most are equal. The pathogenesis, the general pathogenesis in hyper and hypokalemic periodic paralysis is the same. The detailed pathogenesis is different, and therefore a part of the drugs is different. So potassium, taking potassium is good for hypokalemic periodic paralysis and bad for hyperkalemic periodic paralysis. But taking diamox and diclofenamide, or also aldosterone antagonists, is good in both conditions. That's the same here. Difference.
I'm sorry, Frank, can you clarify so you have people used Inspira in hyperkalemic periodic paralysis? Because it's potassium sparing.
I knew you will ask this question because this is a little bit, yeah. Probably we should try it. In the past, I thought so the Inspira will elevate the potassium very highly, and that might be bad for patients with hyperkalemic periodic paralysis. But on the long term, you can forget this increase in potassium. So it's there's no increase. So it helps for other reasons. Not the change of the potassium is the most important for Inspira. There are several ion transporters and opening of potassium channels which shift the P2, the fibers in the P2 state back to the P1 state. So it's not the potassium change. This is very mild, the potassium change.
You could see how difficult this is even for like seasoned physicians. They have a certain logic from medical school about how a drug works. And here we're seeing that a drug works differently from that mechanism that they learned. So this is one challenge that we're going to have to educate people about how these drugs work in periodic paralysis. So it's a hurdle. Anyway, okay.
All right, this is going to be our last question, okay? Can anything be done to create more awareness among doctors, especially neurologists, in Ireland? How about the whole country, the whole world, and other countries about this condition, that it does exist and it can be real if a patient is presenting as normal at a consultation? You know, why do we present with normal potassium when we go in to see the doctor? And also to help neurologists understand that there is a benefit to doing the CM EMG, which is the one using just a hand or a finger.
Yeah, okay. More PPA meetings, more. Yeah, probably more comments on the PPE website and more inviting doctors, and also I think what is most important, the periodic processes are rare diseases, and nowadays there is a lot of work to establish centers of rare diseases. So like in my hometown, I'm now the chairman of the Center of Rare Diseases. And these centers will be installed, for example, in Germany at all university hospitals. And the periodic paralysis is a part of the rare diseases. And to teach medical students and doctors how to treat patients with a rare disease, this is very important also to increase the knowledge about these diseases. And this is a part of the rare disease centers, and this will be done in the future. But it is also very important that patients' organizations help and
Can I add something to
yeah.
that? Yeah, I just wanted to add something. The other day we visited the UCF Medical School here in Orlando, and it was wonderful. But the best thing that came out of this is that by going out to that medical school with Dr. Lehmann and visiting, I have been asked to actually talk to every single medical school class that now goes through UCF Medical School about periodic paralysis. I encourage all of you, if you have any connection to medical schools, in the places that you live, we need to start educating these doctors before they become an MD. So let us know if there's a chance that we can start doing this in other parts of the country and other parts of the world. I see a hand waving back there, and I have to...
Miss, I'm sorry, one question. I'm not clear about salt. Is it good with nitro?
Salt, just about salt.
Nitro, bad with nitro?
He's curious about salt, hypo and hyper.
Yeah, so there are several salts. The usual NaCl salt is not good for hypokalemic periodic paralysis, but you can buy salts in which this NaCl is reduced and the potassium chloride is increased. So this would be much more suitable for patients with hypokalemic periodic paralysis.
And hyper,
Hyper, to my knowledge, no problem with